So the next thing we're going to talk about is our circulatory system. And when you think about the heart and the circulatory system, you can think of it just like a house. You have your walls, you have your electricity, and you have your plumbing. And we're going to start breaking each one of those down, starting with the walls. And so let's go ahead and take a look at this chart. All right, so this is your heart, and basically looks like a heart, but it has 4 chambers, all right? We're going to think of these as 4 rooms. So you have your right atrium, your right ventricle, your left atrium, and your left ventricle. Now, what we need to start talking about then is a little bit of plumbing. So let's go through this. So what happens when blood comes into the heart? It comes in through the vena cava. Now, is this an artery or a vein? It's a vein. Anything that's coming into the heart is considered a vein. Any vessel leaving the heart is considered an artery. So let's go ahead and talk about where this blood flows. So blood comes in the vena cava and it's deoxygenated. It has literally spent all its oxygens giving muscles and tissues the oxygen it needs, and it is coming back for a reload. So it goes through the right atrium into the right ventricle. It does this through the tricuspid valve. Now, it's going to go through the pulmonary valve and go through the pulmonary arteries. Now, are these oxygenated or deoxygenated? Right, these are still deoxygenated. The pulmonary arteries are the only deoxygenated arteries in the body. So here it goes to the lungs, it gets all oxygenated, and it comes back into the left atrium through the pulmonary veins. Now, are these veins oxygenated or deoxygenated? Right, they are oxygenated. These are the only oxygenated veins in the body. So it comes into the left atrium and then goes down through the mitral valve into the left ventricle. From the left ventricle then, it's going to go through the aortic valve, through the aorta, and to the rest of the body. So that is basically how the heart functions in terms of blood flow. But now we need to talk about how does the blood actually get there. You need a contraction to push the blood, and the heart is just a big old muscle. So we're going to talk about systole and diastole. So systole is when the bottom part of the heart, the ventricles, pump blood. And when they pump blood, that's when it goes out from the right and left ventricles to the pulmonary system, as well as to the rest of the body. All right, that's systole. Now, diastole is when we have the relaxation of the ventricles. And when you have relaxation of the ventricles, then blood can come in and fill the ventricles and get ready for the next contraction. So systole and diastole, that sounds an awful lot like a blood pressure, right? So that's exactly what it is. So you know how when you take a blood pressure, it's always, we'll say 140/90, right? Hypertension number. Okay, so 140 is a lot bigger than 90, right? That's because 140 is systole. That's the measure of blood as it's being pumped from the ventricles into the body. It should be high. And then diastole, that bottom number, is a lot less, right? Because the ventricles are relaxing, so the amount of blood pumping through the artery at the time is much less. So that makes sense, right? So systole over diastole. You have to remember that systole is contraction of the ventricles. Okay? All right, so there is something that we can, or there's a graph that we can mark systole and diastole on, and I want to show it to you here. So take a look at this figure. So what you see here is on the x-axis we have volume, and on the y-axis we have pressure. So you see on the bottom there's ventricular filling. What is that called again? Right, diastasis. And then all of a sudden, there's no more volume increase, but high pressure increase. And then it says isovolumic contraction. What that's stating is after the blood has filled the bottom part of the heart, the ventricles, this isovolumic contraction with no volume change means that the heart is getting ready for a forceful contraction. It's building up, but it can't go anywhere yet because the valves are closed. Then all of a sudden those valves open and you see an increase and a significant decrease in volume, but the pressure stays the same. That is ventricular ejection or systole, okay? So during this time then all of a sudden you see pressure decreasing, and again, no pressure changes. That's called isovolumic relaxation. So this is again when all the valves are closed and the ventricles are relaxing, getting ready to be filled again. So as you can see here, I want you guys to remember the isovolumic contraction and relaxation at those times all the valves are closed. This is really important. Can all the valves ever all be open? No, they can't. They take turns, right? And that's actually where we get our first and second heart sounds. So if we were to say like, oh, I can hear his heart, lub-dub, lub-dub, right? Let's talk about what that is. So the lub and the dub are actually closing of the different heart valves. The first sound isn't actually called lub, but it's an S1 sound, okay? So if you see there, under mechanical events, you can see S1, which is the closing of the mitral and the tricuspid valves, all right? First heart sound. Second heart sound then is closing of the aortic and pulmonary valves. You're like, this is kind of tough. I don't know if I can remember this. Well, this is how I remember it, all right? I remember it by try my apple pie, all right? TM over AP. So try my tricuspid mitral valve over the aortic and pulmonary valve. That's your first and second heart sound, all right? Also, when you have closing of the tricuspid and mitral valve, at that time, that's systole, all right? So when you have systole, again, what does that look like? Right, it is contraction of the ventricles because the aortic valve and the pulmonary valve, those are open right now. All right, so blood is going through the lungs, through the body, and then all of a sudden those valves shut, the aortic and the pulmonary valve shut. That's your second heart sound. So what is this? Right, diastole. The ventricles are relaxing, getting ready to fill with more blood. All right, so on this sheet, you'll also notice that there's an S3 and S4 heart sound. Lower yield stuff, I just want you to know though that they do exist. S4, I would also know that means that there is disease. That either means that there is a high atrial pressure, stiff ventricles, something is not going right, all right? So I talked a little bit of blood pressure here again in this box. You guys can read through that, but otherwise, let's start talking about the electricity of the heart. All right, so look at this heart. One thing that's pretty cool about the heart is that it has its own electrical source called the SA node. And the SA node is what we consider to be the pacemaker of the heart. And it can self-generate action potentials, which then is going to spread to other cells. So the SA node is going to fire between 60 and 100 beats per minute. That is what a normal pulse should be. Anything below 60 is bradycardia, anything above 100 is tachycardia. Now, if we look at the SA node, it is going to generate its own action potential, and then it's going to spread it through the atrium to the AV node. The AV node also has slow action potentials, and so it gathers up the electric potentials, and when it's ready, sends more electricity down through the bundle of His and then up through the ventricles. The AV node is important because we need time there to allow blood to fully fill the ventricles, and then it needs to spread down the middle of the heart so that contraction can start at the base of the heart to allow for uniform contraction of the ventricles, allowing blood to get out of the pulmonary and aortic valves. We can also see this then on an EKG. So let's take a look at that. So if you look at an EKG, there's all these different waves, which can be slightly unfamiliar, but let's take a look at them and put them with what's going on in the heart. So if you look at the P wave, it's this little area of depolarization. Remember, if you have a depolarization, you have a contraction. That's how muscles work. So look at that little P wave. That is actually atrial depolarization. So that's what's going on between the SA node and the AV node. And then you see that pause. Well, what's that pause for? That's that AV node getting up all its electricity to send it out to the ventricles. Now you have this huge QRS complex. And what is that? Well, the QRS complex is basically ventricular depolarization or contraction, right? And look how it's in this whole thing of systole. So this is systole or ventricular contraction. And then it goes back to baseline, and there's this little T wave that's actually pretty important in medicine. All I want you guys to know about it, though, is it's just this extra little relaxation of the ventricles that we can see on the EKG. You guys officially can read an EKG now. But that's what the electricity of the heart is. So hopefully you're able to follow that through and understand it fairly well right now. All right, let's move on to arrhythmias. Now we just got done talking about that P wave, and that P wave is super important because if you look there under arrhythmias, extra P waves, no good. All right, missing P waves, no good. It means that you have heart block because after every P wave, you should have a QRS complex. If they're not lined up, then the electricity in the heart is misfiring, and that can cause heart block. or other arrhythmic diseases. All right? Okay, let's move on. So that's a fast action potential. So I think it's low yield, but I also wanted you to go through and understand the difference between that and a slow action potential. A slow action potential does not have potassium in it. Instead, it involves mostly calcium. And calcium has these slow ligand calcium channels so that the calcium can come in and come out a lot slower, allowing for a slower resting membrane potential for that cell. All right, so let's keep moving on. So next is hemodynamics and regulation of blood flow. So blood flow is basically determined by two things: resistance through the vessel and pressure differences at the beginning and end of that vessel. I did put the flow equation there. I don't think you need to know it. So let's go ahead and move on. I do think that you need to know a couple things about flow in general. And so look at that box there. It talks about pulmonary circulation. When we think about blood, the exact same amount of blood is being pumped through the venous or through the pulmonary system and through the body at the same time. But what I want you guys to know the difference of is that blood flow through the pulmonary system should be low pressure, all right? Blood flowing through the body is high pressure, all right? And that's basically what that box says. So the next thing we need to talk about is the Starling forces and that equation. I would try to be able to solve for this equation. To be honest, it's one of my least favorite things in physiology, but you can do it. All right, let's take a look at that equation and start solving for it and learn about what it means. All right? So basically we need to review what the fluid exchange is across the capillary walls. We have 4 different pressures. We have oncotic pressure in the capillary, and then oncotic pressure outside of the capillary wall. We have hydrostatic pressure in the capillary and hydrostatic pressure outside the capillary wall. So let's take a peek at the equation, all right? So when we look at this equation, we have fluid movement. That is what we're trying to solve for. Is it positive or negative? And then we have this hydraulic conductance. We're going to leave that out for now, all right? So basically now we're left with capillary pressure inside and outside and hydrostatic pressure inside and outside. And just to review what hydrostatic pressure is, that is pressure coming from the heart, okay? Oncotic pressure has to do with albumin and pulling fluid out or in according to where the most protein is, all right? But let's take a look at this. So let's solve a problem. Let's say that PC, or capillary hydrostatic pressure, is 30. Now let's say that interstitial hydrostatic pressure, which is PI, is 5, all right? So put that in parentheses, that's gonna equal 25. Now, let's take that minus capillary oncotic pressure, which we're going to say is 6,000, just because, all right? 6,000 minus the interstitial oncotic pressure, and we're going to make that 5,975, okay? Subtract that first, and now you have 25 minus 25, which is 0, all right? So what does that mean? Well, 0 would mean there is no fluid movement. All right, let's change our numbers a little bit. Let's make it 40 minus 5, okay? 40 minus 5 and leave the rest of the numbers the same. Now we have 35 minus 25, which gives us a positive 10. Well, what does that mean? Well, if you have a positive JV, a positive fluid movement, that means that you have fluid going from the vessel to the tissue. All right. A negative JV would mean that we're sending fluid from the tissue to the vessel. All right, I know that that is no fun to learn that equation, but you will totally dominate this on the test. And if they do have something, the big picture is make sure that you know what positive JV and minus JV mean in terms of flow. All right. Okay, good job. All right, let's keep going. We're going to talk about blood pressure now. So again, we're talking about neuroregulation of blood flow, as well as we're going to talk about some renal regulation of blood flow. So when we talk about neuroregulation of blood flow, this involves our baroreceptors, okay? So baroreceptors are found in the aortic arch as well as the carotid sinus, and they can sense changes in blood pressure, and they do that via the autonomic nervous system, okay? So if you keep looking there, I want you to highlight vagus nerve. Vagus nerves is what sends up our information from our aortic baroreceptors, and then highlight the glossopharyngeal nerve. That is what sends our carotid baroreceptors, all right? They send both of these to the medulla oblongata, which remember also is the rhythmicity center of the brain too, in terms of our breathing. Now, we need to be able to increase or decrease our blood pressure via the sympathetic stimulation or parasympathetic stimulation to control what our blood pressure needs are. Another way that our body does this is by using ADH, angiotensin II, and aldosterone. We're going to talk a lot about this in a little bit, but basically those are all hormones that add fluid or cause vasoconstriction to, again, change the blood pressure. And we'll talk about that a lot in a minute. Also then, we're going to talk about how the heart pumps in terms of changing our blood pressure. And this is important. So when we talk about how much our heart pumps, that's our ejection fraction, okay? When the heart is pumping a lot, guess what? The pressure goes up. Ejection fraction, if it's not pumping as much, gives us a smaller fraction. And now we say a person who's healthy has an ejection fraction of 50%, meaning they're pumping out 50% of the blood, all right? Anything less than that, a patient actually has congestive heart failure. So that's another side note to know for congestive heart failure as well. So if we look at ejection fraction, there's just this little equation, and basically ejection fraction is end diastolic volume, okay? So at the end of diastole, how much volume do you have, minus the end of the systolic volume, so how much blood is now gone, basically, over end diastolic volume. So basically how much blood can you get rid of over how much blood did you start with. So the next concept here too is cardiac output, and basically cardiac output is the amount of blood that one can eject in a certain period of time. So there's different things that involve cardiac output, and I want to make sure that you know them. So if you go to the next page, you see that cardiac output equals stroke volume, so how much blood you can get out, times heart rate, all right? And there's different things that can increase or decrease this. If you look at the variables, look at that number one, contractility, right? The more calcium you have, the better you contract, the more cardiac output you're going to have because you have more stroke volume, all right? Also, there's something called afterload and preload, all right? Preload is basically ventricular end diastolic volume. And you're like, okay, so basically how much blood is in that heart. Now, one thing I want you to know is the more you can stretch that heart, the more you can put in there. And so that would be how much fibers are involved. All right, and your board's actually asked a question about this, and let's go ahead and put that question up there and see if we can work our way through it. Right, increased end diastolic fiber length. So the longer the fibers, the more you're able to have more ventricular filling and a more forceful heartbeat. Hence, higher stroke volume and a higher cardiac output. All right, so also look at that box at the bottom there. It says stroke volume increases when preload increases, afterload decreases, and contractility increases. So basically, the more you can put in there, the more you can squeeze out. The harder you can, obviously, the higher the stroke volume. All right, let's keep moving on. Everything that we just talked about can be described in the Frank-Starling mechanism, and I would go ahead and reread through this. But basically, again, it's saying the more blood in the heart, the more blood you can hopefully be pumped out, okay? Also, I put another box in there, and it's just what we had that question about, was basically this idea of length of cardiac myofibers. I would review that as well. And then there's more things that can affect cardiactility and stroke volume too, and I put them there. So let's just review them. First, the more calcium. The heart needs calcium. More calcium you have, the harder the contraction, all right? Muscles need calcium to contract. Next, if you have more sodium, that can also cause a harder contraction, all right? Digitalis is a medicine that we can give to patients who, for example, have congestive heart failure. That goal is to also strengthen contraction because it increases cellular sodium. And then also sympathetic stimulation, so epinephrine, norepinephrine. Or if you think about it, if you go running, then that's also going to increase the amount of contractions that you have. Factors that can decrease stroke volume and contractility, well, heart failure, that's a big one. Also, if you have a myocardial infarction or any other damage to the heart, that's going to decrease it. Also, anytime you're in a hypoxic or acidotic state, that also is going to slow the contractility of the heart. I also have in there chronotropy and ionotropy. I would just read through those terms just to make sure that you know those as well. Basically, that also, if you increase that, it's going to increase the force of contraction as well. So take a peek at that box.